And welcome again to The Doctor Is In. It's brought to you by Bay Area Medical Center. I'm your host, Jim Callow, and with me today is Dr. L. Jack, who has returned to Bay Area Medical Center after being away since 2015 down in Florida as the Chief of Urology at the VA Medical Center West Palm Beach and an affiliated program to the Cleveland Clinic Foundation. Dr. L. Jack has been part of Aurora Bay Area Medical Group since the fall of 2017. Dr. L. Jack began his career at BAMC in 2002 and was instrumental in developing the Bay Area Urology Clinic, which is now the Aurora Bay Area Urology. Dr. L. Jack has special interests including laparoscopy and urological oncology, laser prostate surgery, female urology, and incontinence, and infertility and sterilization. Lots of big words, but we got through them, and we welcome you again, Dr. L. Jack.
Thanks for having me.
All right, we're going to talk today about the prostate, and I'm sure that most men know what it's about, but let's start at the basics. What is the prostate?
Well, the prostate is a gland usually the size of a walnut sitting at the base of the bladder that usually regulates the flow of urine and also the flow of semen. And the reason why we have prostates really is because 20% of the semen is actually made in the prostate. Most people don't know that. 80% of the semen is actually made in the testes, 20% is made in the prostate. It does tend to get larger with time, and we really don't know why it gets large. But above the age of 40, the prostate starts a process called benign prostatic hyperplasia. Big word. Meaning that the prostate does enlarge in size and causes constriction of the urinary channel. That's why people start getting symptoms.
All right, so about what age you say, about 40 or above is when it starts to cause problems, or when it starts enlarging?
It starts enlarging actually at the age of 40, very rarely before the age of 40. There are some patients who do get enlargement before the age of 40 based on family history. They probably have a genetic predisposition to enlargement, but mostly at the age of 40. When you look at symptoms-wise, 50% of men between the age of 50 to the age of 60 will have prostate problems, and between the age of 60 and 70, 80% of patients will have some sort of symptoms. Above the age of 70, 100% of patients will have symptoms. So it's an age-related process that defines what symptoms you get.
All right, let's talk about the symptoms.
Yeah, usually the first symptom that the patient will experience is waking up too many times at night. Most of the patients will come forward and say, you know, I used to sleep throughout the night, now I'm waking up once, twice, 3 times, and some patients every 2 hours at night time, which makes them very tired. And that's actually what brings them to the doctor. Another thing that they complain of is frequency and urgency. They have to go to the bathroom every 2 to 3 hours. They used to go to the bathroom 4 to 6 hours. And one important symptom within that frequency is that when they do go, they actually say usually that I have to come back and empty my bladder again within less than 2 hours. So I feel incomplete emptying, which is another symptom that the prostate produces. Leakage of urine can happen, and we call it post-void dribbling, which is basically leakage at the end of urination, which many patients find it they are very unaccepting of that. At the very end of urination, they don't even feel they're urinating. It actually just trickles out, and in many cases it wets their clothes and what have you. So.
Now, there's also the problem of a weak stream, right?
Yes, I mean straining to urinate and a weakened stream is a later symptom. These are the earlier symptoms are called the irritative symptoms, which we just described, which is waking up at night, urgency and frequency of urination with dribbling. But what you described is actually obstructive symptoms, a later symptom that they get a weakened stream. They sometimes go into actual urinary retention. They can't pee at all, and also they have to strain to get the urine going. Before, we don't really think about it. In our 20s and 30s, we just urinate. Now we have to wait. There's a waiting time before the urine starts. We have to push hard to get it going. And also when it does go, it's a very weakened stream. And many patients come and say, we trickle it out, we don't urinate.
So we've described the problems. Patient comes in. What type of test do you do to determine just what the issue is?
It's very important that the patient gets a full assessment, and we really don't jump into testing as much as we listen to what the patient has to say, because in many cases, actually the multitude of patients would be very early symptoms that don't require much testing. But a full history and clinical examination is of paramount importance, especially examining the prostate itself. Because to a urologist with a lot of experience, it's very easy to determine just by clinical examination whether this prostate would be producing the symptoms or not. Also, clinical examination is very important to rule out cancer of the prostate. Cancer of the prostate usually doesn't have any symptoms, but in many cases it's actually presents itself in relation to an enlargement of the prostate. So they could be going on at the same time. So we have to exclude cancer of the prostate through an examination. But there are some simple office tests that we go through. We check the urine for any infection. We also check the PSA, which is a blood test for prostate cancer screening, but also gives us an idea of whether the prostate is enlarged or not based on certain algorithms, age-related algorithms, in terms of what the expected PSA would be. In moderate to severe cases with symptomatology, we resort to doing some simple office tests, which is a camera test of the bladder called a cystoscopy, whereby we insert the camera right through the channel of the urine under numbing medicine, and both the patient and I look at it on the TV screen, look at their prostates and see how big it is, whether it needs addressing or not. Some patients with some neurological problems may require further testing in terms of bladder pressure testing that we do in the office called urodynamics. And in rare cases where the PSA is too high or our clinic exam gives a suspicion of cancer, we resort to doing a prostate ultrasound and a biopsy.
Mm-hmm. All right, so we've got Dr. Eljak as our guest today on The Doctor Is In, and we're talking about prostate issues. And when you're looking at doing a treatment, you've got a couple of options, a couple of ways to go, correct?
Absolutely. The important factor here is that we have to determine whether the patient has mild, moderate, or severe symptoms, because the treatments differ. For mild patients, and we score them based on an actual score called the International Prostate Symptom Score, and that's a validated score. It's just basically the patient fills a form, and through that form we will be able to establish whether they have mild, moderate, or severe symptoms. For mild symptoms, it's basically just lifestyle changes. There's no actual specific treatment required, because at that point it's not bothering the patient. In general, we ask them to limit their caffeine intake, their acidic food intake and drinks. Also limit alcohol intake. Avoid decongestants that some patients may use regularly. Antihistamines also can slow down the bladder, so we try to avoid that. We also advise them on double voiding, meaning urinating twice instead of urinating once, to avoid the dribbling. For moderate patients, we probably will start a medication. There are different medications in the market depending on the patient's age and actual other disease, what we call comorbidities, other medical problems that it may have. In general, alpha blockers. Flomax is probably the most famous of all the alpha blockers in the country, and basically the medications are two types of medication that we use for intermediate or moderate symptoms. One is a medication to open up the prostate and allow the patient to urinate, and the other type is called the finasteride or 5-ARIs, which is another fancy name for 5-alpha reductase inhibitors. Basically they shrink the prostate and actually cause loss of volume of the prostate that increases the channel opening of the channel, and then they urinate better, or a combination of both. So there is medical therapy for moderate or intermediate. For severe symptom patients, we're talking surgical. In most of the cases, we have surgical cures for that.
All right. Is that a one-day outpatient thing that you can do, or?
Yeah, there's a myriad of treatments when it boils to surgery of the prostate. The most important factor to consider when we're embarking on doing a procedure for the prostate is that whether medical therapy has failed or not. So the first step definitely is medical therapy, which is the lifestyle changes and medications. Surgery-wise, all depends on the patient's age, whether they have significant medical problems or not, other medical problems, and also the size of the prostate. Milder symptoms or intermediate symptoms that are not resolving on medical therapy, or if the patient is having significant medical problems with heart disease or lung disease that are not candidates for having a general anesthetic, we recommend an office procedure called microwave therapy of the prostate, which is a very neat procedure whereby literally you could be reading a paper or a magazine while your prostate is being treated in the office for about a 25 to 30 minute procedure. We numb the prostate again with numbing medicine, and the local anesthetic, we insert a tube called a catheter into the bladder, and there's a segment in that tube that delivers microwave treatment to the prostate through the channel of the urine. It takes about 30 minutes. We take out the catheter, the patient is done, they go home, and within 3 days of that procedure, we bring them back, do a reassessment on how they are emptying, and beyond that, within 6 weeks from that, they will have 100% improvement in about 80% of patients with a small prostate. Larger prostates, or patients who are fit to be put under general anesthetic, we recommend a laser procedure of the prostate, whereby we put the patient to sleep, going with a camera through the channel of the urine, and laser the part of the prostate that's actually blocking the urine, which takes about 40 minutes under general anesthesia. The patients will go home. It's an outpatient procedure, and will have a catheter only for one night, which is a tube in their bladder that will be removed in the morning. And I usually promise them that they will pee like a 20-year-old, and I haven't broken my promise 2,000 cases later.
These both sound like fairly recent treatments that have come along, right?
Yes, in general, the microwave therapy took off about 6 to 8 years ago. The laser surgery has been around since 2004. It has been refined though. We're working on third generation laser energy within those 14 years. But yes, it has been refined quite a lot in terms of delivery of the laser itself, in terms of the power of the laser itself. So it's a very efficient procedure with minimal bleeding whatsoever.
That's just amazing how technology keeps evolving.
Oh, absolutely, absolutely. The old techniques, you didn't ask about what happened before 2004. The old techniques were using electric current to actually cut tissue of the prostate, and what we call a transurethral resection of the prostate. What a more known term is TURP. It involves removing tissue with a camera, similar to the laser, but the difference is that the patients would had to spend about 3 days in hospital with a catheter for about 5 to 7 days with a significant amount of bleeding. And that's no longer the case. I don't recall the last time I've done one. It has been largely replaced with laser surgery. So.
I'm glad we're living it today.
Yes.
All right, Dr. Eljak is our guest today on The Doctor Is In. It's brought to you by Bay Area Medical Center. And we've mentioned it a couple of times, but let's talk about prostate cancer, which, all the other problems we've talked about so far probably don't involve cancer, but may. So what do we do to make sure that if we have the cancer, that we're aware of it?
Absolutely. Prostate cancer is the commonest cancer known in medicine, both male and female combined. We're talking about an incidence or an occurrence of 200,000 new cases per year of prostate cancer in the United States. Prostate cancer is a very silent disease. Very slow growing tumor is the slowest growing cancer known in medicine. Definitely does not produce symptoms until a very later stage. we always take the opportunity when we're screening patients for enlarged prostate to screen for cancer. Why? Because both occur at an older age. Both occur above the age of 40. Both occur at the highest incidence above the age of 60 or 70. So it would be prudent at the time of just investigating for enlargement of the prostate to actually make sure that the patient doesn't have cancer of the prostate at the same time. We know that enlargement of the prostate is an age-related process, and I don't want people out there to think that if you develop the symptoms we talked about, that they automatically have prostate cancer. Actually, they don't. Prostate cancer is, as I said, is asymptomatic. It does not produce many symptoms. But we definitely have to screen for it. The way we screen for it is initially we do a prostate exam at the time of enlargement of the patient presenting with an enlarged prostate problem, and we also do a PSA. Between the two, if any one of them is abnormal, we do a transrectal ultrasound guided biopsy of the prostate, which sounds drastic, but it's a 3-minute office procedure. We're under local anesthetic. And actually, my patients don't stop talking to me while I'm doing the procedure, but within a 3-minute span, we take samples from the prostate and analyze it for cancer. And usually the patients will get a result within 24, 48 hours. I have to allude to the fact that in many cases, prostate cancer coexists with an enlargement of the prostate and may or may not be detected with all this screening. All this screening is very efficient. It detects probably about 85 to 90% of cancers, but in some cases, during the actual procedure of prostate treatment, if we remove tissue through a laser procedure, we actually find prostate cancer. In probably about 5% of patients, you might find prostate cancer that wasn't diagnosed with the conventional office procedures. But in general, the conventional office procedures are up to about 90% accurate.
All right, and that's getting the PSA measured. I know I've had that as part of my annual physical for a number of years now. Sounds like that no matter what you do, eventually it's going to catch up with you, huh?
Yes, and you know, I just wanted also to mention real quick that prostate enlargement is not just a lifestyle problem. It can lead to very significant problems. If these patients do not present early, they can run into a urine retention, which is a very painful condition whereby they cannot urinate at all, and they will have to present to the emergency department or see their doctor, their urologist immediately for placement of a catheter. And I don't think that's any fun to anybody. Another thing is that it can cause infections in the bladder, can cause infections in the kidney, can cause bladder stones, can actually cause kidney failure, because if the urine is not going out through the channel of the urine, it's going to back up to the kidneys, and basically I've seen a couple of patients end up on dialysis in the last couple of years with enlargement of the prostate. So it is a significant problem. And in terms of lifestyle and what we call home remedies, we generally tell the patients if you actually exercise and lose weight, you will generally maintain prostate health. How is that relevant? Obesity has been found to actually be a risk factor for early prostate symptoms. It's a risk factor for diabetes, which actually compounds prostate symptoms, because in diabetic patients, you will have a lot of urgency and frequency and producing large volumes of urine, which compounds the problem. Also, I generally tell my patients, do not delay your urination. Many people at work or have a very intense job, they delay the urination. I generally would advise within 4 to 6 hours to actually empty the bladder, not delay the urination any longer, because it causes stagnation, bleeding, infection, and can compound prostate problems. Also, in terms of caffeine, people love caffeine, and I think caffeine is a good thing for lifestyle, but also a bad thing for the prostate. Caffeine, I advise my patients to actually go completely on decaffeinated coffee, because caffeine will cause a lot of urgency and frequency and will even have early symptoms and early onset of prostate problems. Alcohol is a big problem with that, because not only it produces large amounts of urine, it also alcoholism leads to obesity, and obesity has been labeled as a risk factor for prostate cancer. whenever anybody goes to the bathroom, I generally advise them to actually double urinate, not urinate once. Like when you think you're done, try to urinate once more before you actually walk away from the bathroom. So double voiding or double urination is very important. Also, to urinate before going to bed and do the double urination before going to bed will make you sleep throughout the night without any problems. Another thing is people have a tendency to drink a lot of liquids before they go to bed. And they generally say, oh, we're thirsty and what have you. But when you drink a lot of liquids just before going to bed, at nighttime we're not as active. We're asleep. We're not as active as daytime, so we don't lose liquid through perspiration. So most of what they drink is going to come out in the urine, and they will eventually have to get up at least 2 to 3 times during the night. So we generally tend to tell the patients to drink most of their liquids during the daytime, not at nighttime. Again, this may be more related to prostate cancer than alarm with the prostate, but fatty food and fatty diets have to be avoided, as well as obesity, because it carries a very high risk of prostate cancer in those terms.
You keep saying obesity. I think there's a
Yes.
message in there someplace. All right, if someone wants to reach you for more information, where do they find you?
Yeah, they can call my office. It's a straightforward phone call. We'll get you in at 715-735-8064, or they can reach me through our website, or they can even reach me through social media that we have. We have many accounts in social media that they can reach me through.
All right, so, well, hopefully we've described a lot of the problems that prostate can cause, and maybe some people will recognize what's happening and get some help when they need it. So,
Absolutely.
appreciate having you with us today. And Dr. Eljak from Bay Area Medical Center, from the Aurora Bay Area Medical Group. He's been back since the fall, and glad to have you back in town.
I'm glad to be back too. Thank you.
All right. That's the Doctor's In for today. It's brought to you by Bay Area Medical Center. I'm Jim Callow. Have a great day.